We're talking today with Dr. Jasveer Mangat from Great Ormond Street Hospital, and he's generously given his time to give us his impressions on the OneStim device, how he uses that, and maybe what you would like to do with it in the future. So thank you for your time today, Dr. Mangat.
Thank you. And thank you for letting us borrow the equipment, actually. I suppose the background for us is that we've been thinking about how we interact with our newborn babies and some of our babies on the ICU. We had historically these large pacing boxes that took 10 or 12 9-volt batteries to do esophageal pacing, but we've not replaced them. We've had some temporary pacing boxes. And there's limitations with that. You've got a paper screen, your ECG screen, and the outputs are hard to manipulate. So when you came along and offered us an all-in-one system with a format we're familiar, it seemed a good option, actually.
Could you tell us a bit about the electrophysiology program that the hospital has?
So we're attached to a really large centre for children. We have a few specialist programs which makes us a bit unique to the rest of the UK. So we have a cardiomyopathy program, an ECMO program, a transplant program, and a pulmonary hypertension program. So by default, then we get some of the sicker infants from the other centres, and our arrhythmia service largely caters for our region, so the patients that are born or living in our region, plus some of the super specialist services. So some of their patients will have arrhythmia issues on top of their primary, cardiomyopathy, transplant. So we look after that whole group. And then fortunately, both for us and the hospital, we have a cohort of patients from overseas that come for treatment here. So we're a large centre for children. So compared to my adult colleagues, we do barely nothing. But it's around 110 EP cases a year, and a steady sort of 25, sometimes 30 defibrillator type cases a year. So for a paediatric centre, especially in the UK, we're on the larger side. Some positives to that in that our lab program's quite mature. So having, lists twice a week means that our physiologists can be to a really high standard. And then we've got a really strong link with Bart's Heart Centre. So as our patients get to 16, 17, 18, they transition over. Our expertise across both sites. So our adult congenital programs there, but colleagues across, we cross work. And we've done the same with our physiologists. So they're not stuck just looking after children. They're off to Bart's and constantly interacting, which, unlike your program with the OneStim, does mean that for novel devices, changes in technology, we're kind of alongside rather than being siloed, just waiting for something to turn up for children.
Could you explain to us a little bit about the types of uses and types of procedures you have for it?
When you outlined it to us that it's an EP recording system plus the micropace we're familiar with, it does exactly that. So it has a live screen. We can put the numbers of channels a bit restricted compared to the EP lab, but enough for the bedside. So our use so far is a small number of cases, but we've used it for patients post-surgery in atrial arrhythmia. So we've come along to the bedside, we've noted the tachycardia, we've seen the variable rate, sort of wondered whether it's a flutter or not, simply plugged in the patient's atrial pacing leads into OneStim as you would in the EP lab, and we've got the surface ECG. I think for that one case we didn't bother to reference with the ventricular lead, but in hindsight for conduction issues maybe that would have been worthwhile. And it's simple as you're not guessing. You're not on a piece of paper trying to draw numbers and decide. You press the review screen, you can measure the atrial cycle length, and then you can time whether you're overdrive pacing or putting a sense day in. Of course, the challenge in tachycardia is knowing the capture threshold. But on the ICU and someone anaesthetised, it's easy. You just go for a nice high output and get the job done.
Okay.
So it's quite an elegant way to come and pace terminate an SVT.
Are there any other use cases? I think you mentioned that you're also doing some transesophageal.
Yeah, so we've had one opportunity to use a transesophageal, and then that's where I got to see some of the functionality that you wouldn't have had from a temporary box.
Yeah.
So called from the IR lab, so someone had put a neckline in, the line into the atrial caused an atrial rhythm for this premature 2-kilo baby. The team at the bedside or in the ICU had patients under anaesthesia had given adenosine, which allowed the rhythm to slow but reinitiate. So they called for help. Mm-hmm. So the adenosine had caused AV block but not terminated the atrial arrhythmia. And it seemed far more elegant to try the OneStim than Cardiovert. And in that process, we got to see that we could pace at really short intervals. So I don't know whether that's for research in the animal lab or whether you've done that intentionally, but you could pace right down to 150 from memory. I don't know if it goes any shorter than that, but we certainly got to terminate the the atrial arrhythmia by overdrive pacing at 150 milliseconds.
Yeah. Equipment you used for that with the OneStim, did you use a transesophageal catheter or were you using just a normal?
No, so we just had the anaesthetist pass it down. Mm-hmm. We didn't have any fluoro. We simply watched to see where we got A and V.
Okay.
And as soon as we got A and V, we tried to get on and pace.
All 4 bipoles or
all 4
connected?
Plugged in. Yeah.
Yep.
Yeah.
Okay.
I suppose we have a little experience with esophageal electrodes from the EP lab. We don't use them often. So we've had the FIAB catheter on the shelf for a while, and every year or so, difficult to get in the left atrium or difficult to get access to a small child, we'll put one down for an atrial signal. But yes, we're not so familiar as to what it looks like. I suppose when you first see it, you see the A and V and you're not quite sure, but I think it's hard to get a pure A.
Yeah. Do you, with transesophageal, do a threshold or what's your approach to capture there?
So really new to it. The last patient we used it on Friday evening, I opted to let my registrar carry on while I went home, which was fine, except the issue that they had was the discomfort of getting the tube down. So, the nurses are super familiar with passing an NG tube, but we have this odd situation that intentionally, where if a child comes to us in incessant SVT, they're usually quite compromised. And we know the act of intubating them and putting them onto a ventilator can be quite risky because you drop their vascular resistance and they can crash. So often those children come and we're quite slow. So amiodarone is loading, they're cool, their heart rates are gradually coming down. We haven't taken a proactive step. So in that setting, the baby can get agitating just getting something down the nose. So I think getting a feel for how to get the esophageal electrode down to an awake infant, we're not there yet.
Okay.
Just haven't got a feel for how uncomfortable that might be.
And you did go nasally. You haven't thought about
haven't no
going down the back of the throat.
Yeah, it'd be interesting to hear what others are doing actually.
Output, you probably just go for a good output where you get capture. And did you also look at the pulse width that you were using as well? Or?
Yeah, so experience is limited. I think ideally you'd want to do it all, wouldn't you? You'd want to get the threshold and the pulse width and then as comfortable as possible for the infant. The occasions I've used it has been an emergent situation, child under anaesthesia. So I've ramped it up to the highest threshold and a pretty long pulse width actually. Yeah. Just so that you capture the atria and you break the cycle and move on. So, but yeah, haven't had the chance to see what it's like to do a threshold.
Okay. Right. Are there any other areas that you, since receiving the device and now using it a couple of times, and are there any other things that you've thought that you would like to do with OneStim and other diagnostic testing or
I think if there's 2 things that come to mind. One is if our staffing is such, or we can simplify the workflow and have physiologists or nurse practitioners involved, is to use it as a primary treatment. So rather than some sort of infant coming in, you're using amiodarone to cardiovert their flutter, or you're waiting for them to be intubated to have a DC cardioversion. This might be a much more rapid step So repeated dose of adenosine you could avoid. And while you're getting your pharmacology right, and you've got the setup at the bedside, patient has a recurrence of their arrhythmia, you simply pace terminate them. So it'd be quite a comfortable way to manage a child. It's getting there. How do you cater for that one person who turns up every 3 months or every 2 months at whatever time they arrive, and then at whatever different states or ages that they are. So it'd be nice to use it for that. We have had opportunity just simply moving labs. We had a patient with an incessant tachycardia, so we didn't have a big burden in terms of inducibility or testing or entrainment manoeuvres. And we simply went ahead with a mapping system and OneStim in that setting. So we much less hardware than needs to be moved around.
I think you mentioned potentially medication titration could be an area.
So I think that would be really useful. At the moment it's blind. So for 2 settings it's blind. It's blind when the child has had SVT and you've treated them and they're outgrowing their dose. You don't know if they have that substrate for SVT still. So you either leave them on pharmacology until an EP study at preschool or school age, or you take them off the pharmacology and wait to see what happens. So if, as others have reported, we've not tried, if esophageal pacing is comfortable, you can do it in an outpatient setting. Potentially that child, you'd know whether they need 2 more years of pharmacology or not without a formal procedure or a general anaesthetic. And then the other setting, which could be really important and prevents readmission, is infants come in SVT, you've got control, but you now don't know whether there's enough antiarrhythmic on board to discharge them. They've been fine for a few days, but will they be fine in 2 more days or 3 days? And if you can introduce some atrial ectopy then, or do some pacing manoeuvres at that point, you then know if you're safe enough to send home. So that bit's a bit blind. And you can kind of imagine as a family, when you explain, you come in as a clinician and say, we've treated your child, they're now much more stable. You can go home, but look out for these things because it might all happen again. And I don't know if it'll be tomorrow or in a month's time. And if we had some way of saying, actually, you're going to go home, we're pretty happy. It's pretty robust. Or really sorry, you're not going home. Things look okay, but we need to do more. There's more to do here on the pharmacology and titrate up. So I think that role would be really useful. I don't yet have a concept of how to roll it out. How easy it is to pass the probe, and what's that level of discomfort we're exposing the patient to, and then what's the pacing feel like. So we haven't seen that yet. Okay.
How do you see, obviously, you're saying it's a nice device and you want to introduce it. And you say, how do you see that? Have you had some thoughts about how you would do that and how you might be able to expand your program so your colleagues from other...
Yeah, I don't think it's inconceivable because the teams on the ground are pretty familiar with standard arrhythmia. So they, middle of the night, they've been managing jet or flutter or reentrant tachycardia for years. So they know what the 12 lead looks like. They know what the 12 lead plus an atrial EGM looks like. They're pretty familiar with putting an atrial lead in a post-op baby onto the 12 lead. So they know the relationship of A and V. When we can add to that, and we're not changing much, we're just changing that paper strip to a screen, and we're animating it differently. If we can make that make sense to them, so instead of looking at they've taken the atrial lead out of the box or the wires and they've plugged it in, they're just reimagining the same thing on a different platform. So it's no different to what they're doing anyway. And if there's some simple steps then to say you've now captured that ECG, just as you captured the 12 lead, you press print, you've now captured it, you've pressed review. So you've got that. So you've got your ECG and you've got the atrial signal, the ventricular signal. Your job now is to determine whether there's 2 atrial signals for every V or whether there's 1. If there's 1, all you need to do is either pace the atria a little faster than that number that you've generated, measuring the 2,
or you're pressing this button to put an extra in. So I don't think it's massive actually. I think if it may take a couple of people to buy into it and get over the fear of looking at some colours and some moving signals rather than the ECG.
Yep.
I think it's manageable because people have been wandering around the ECG for years, haven't they? And sort of have a look at this, have a look at that. This is now just a clip, right?
Yeah.
So they could send me the clip, or they could, it doesn't have to be that difficult actually.
But is it the electrophysiology team that's always called upon for the support of it, or could a PICU,
I think they could, right?
cardiologist
They
become...
use pretty complex stuff in there, don't they?
Yeah,
I mean,
yeah,
they're putting people on ECMO, they're doing all sorts of stuff. So to turn the machine on and press review we could simplify it. We could just have a preset with the channel that we're interested in, and then it's obvious to them, right? If you start with a post-op group of patients where you're not adding hardware, so it's already on the patient, and you're simply plugging it in, and you're moving from one modality to the other, they could still get a printout if they wanted on a PDF, right? So I think it's conceivable that there'd be a setting where our ICU doctors would be comfortable to have OneStim at the bedside, and not the 12 leads, unnecessary. They've got the 6 leads that you have, and the atrial signal, and it's all that they need. It's so simple. It's not VT ablation. There's nothing else going on. It's just it's an ECG plus some pacing, right? So
I used OneStim a few times now. Are there any things about it that you see that we could improve, or anything we could add, or have you had any chance to think about, if this was a little bit different, or if they added this would be a bit more of a useful tool?
Yeah. 2 things. One, I mean, we talked about the noise on the patient, and you've given us some earth cables.
Yeah.
If we could we could slave it. The day that we use it in the cath lab, we couldn't find on the monitor that was facing me where to plug the cable in.
Yeah.
So I think, some familiarity on our side, just slaving it so we can see the screen. The second is if the review and the live could be separate. So if we could have, at the moment there, one on top of the other. So
one screen.
Or you split the screen.
Yeah.
So if you could have the 2 screens on the same, so you don't have to change your hardware, but you could have 2 split screens. And then as a projection, that could be 2 bigger screens.
Yeah, yeah.
Then we'd have a functionality that we could use in the cath lab.
Okay. One other
which means that if you move lab, or your lab's broken down,
Yeah.
you've got a really simple bit of hardware that you can move across and use anywhere. So we're fluoroscopy free. So if our cath lab breaks down, I don't need the cath lab. Just need a mapping system and a recording system.
Yeah. Good point.
So with the magnetic mapping systems, of course, there's some calibration, all the rest of it we've got to be set up. With the impedance-based systems, we could be anywhere.
Wow.
So in the past, we've moved our BARD system up and our EP system up to normal theatre, but this would be easier. You just have your little EP in a box and a mapping system, and off you go.
Fantastic. So when you do some testing and you go into the review screen, that's how you, one suggestion I put forward was maybe after the end of pacing, it just automatically saves that pacing event, the whole of that pacing event. And then you just open it up and review that pacing event. Or you could keep doing pacing events.
Yeah.
And then
go back as needed.
Just then open up. And if we had a box with, the last 6 or whatever, you just go through the different pacing events.
That would work. Yep.
Yeah.
Yeah.
How have you found the work moving between the screens? Because you did mention that as an issue of the, stop, pace, review, then go to do. How do you find that
I guess we probably haven't got familiar enough, right? So I'm not sure. I don't know. I think it'd be fine. I think for a workflow in an EP lab where you're just, you're testing,
either to see your efficacy or determine the mechanism. The indication for us outside of the EP lab is a bit different. So actually you just need to capture the primary rhythm abnormality and then whatever maneuvers you do. So I think the time pressure is different.
Look, thank you very much for your time today.
Super, thank you.
Thanks for answering some questions.